My name's Louise McKinley, and I'm the Director of Patient Experience and Partnerships at Safer Care Victoria. Now, I'd like to begin and acknowledge the Wurundjeri people of the Kulin Nation, who are the traditional custodians of the land on which we meet today. I'd also like to pay my respects to elders both past and present, and extend that respect to the elders from other communities who may be here today. And being my first, official event in this role, I was keen to understand a bit more about the land on which we're meeting today. And the team did a great job in finding some information for me, and it is indeed a significant area. And across the road where Parliament House is, this used to be quite a significant meeting area. So many, many years ago, the traditional owners in this area were a confederation of clan groups who came together under a collective name, Kulin. And the Kulin included the Watha Wurrung, the Taung Wurrung, and Woi Wurrung, and Boon Wurrung. So apologies if I've pronounced any of those incorrectly. But however, as a people, they moved around their territory according to availability of food and the weather, and visited sacred and ceremonial sites, such as hills and creeks, places that they saw as having power. And across the road was one such meeting place. And this was favoured for special guests and special ceremonial purposes, such as corroborees. And basically they brought the clans together, having dancing displays and welcome visitors and celebrating their special events. So what a privilege it is to meet here today, and how apt today to have a special guest. Can't promise there'll be any dancing, however, I'm really proud that we're here. Now, I do want to make special mention to our many guests who've travelled here today, but also we have a number of people online. So we're live streaming today. And just to let you know, we are filming the session, but we're actually recording the slides, not you. So if any of you are camera shy, please don't fear, you will not be streamed live anywhere in Victoria. When we do come to the questions later, what will be recorded is voice and response, but again, there'll be no faces, and we'll be managing online questions with our online guests through, they can log in and email those questions through the link that we've sent them. And I'll talk to you a little bit about social media shortly, but the sort of run of the afternoon is as follows. I want to take the opportunity to talk to you a little bit about Safer Care Victoria and what we're about and what's ahead. Obviously, we've got a lot to hear from John about in terms of person-centred care and the value-based care that you can achieve through that, and partnering with patients and their families and carers, and the use of patient-reported outcome measures. To have a bit more dialogue and hear from John, and then we'll open up for some questions at that point and aim to finish for 4:30. Now, some housekeeping. We do have toilets just through the double doors here along the corridor, and there are some toilets through the double doors there as well, just outside. I'll take you through the question session as we get to that. Certainly when you do ask a question, if you can sort of say who you are, and if you're typing in a question, please start with what your name is, where you work, and go for your question after that. So social media, we are really keen that you engage with us and follow us on social media, so feel free to tweet throughout the session, and this also goes for our colleagues who are far afield and are listening to us online and watching the show, as it were. And the hashtag for today is SCV events. Being mindful, obviously, if you can pop your phones on silent, we don't mind you using them, but to tweet and to comment on today, but obviously if you can keep those on silent would be great. So let me talk to you a bit about Safer Care Victoria, and this will not be news to you, I hope. Many of you will be familiar with the Duckett report, post-Jarrawarra, and the findings around what we can be doing to improve across the system in Victoria. And essentially, Safer Care Victoria and the Victorian Agency for Health Information have been newly formed in response to that. But with a longer term game, I guess, you know, we're in a time of major reform in health, post-Travis review a couple of years ago, establishment of Better Care Victoria, which is now part of Safer Care Victoria. We've got a real agenda ahead of us around improving the system for our patients and our communities. And certainly we're very committed at Safer Care Victoria to assist you in health services and as well as within at the Department of Health and Human Services on how we do that better, how we get access to the right data in a timely manner, how we amplify the patient voice and hear their messages and their stories and listen to how we can improve the system overall. So it's a unique time in Victoria, and it's very exciting to be part of that journey from its inception. Although I'm officially only 3.5 weeks old, and I think Safer Care's 12 weeks old, so I'm catching up a little bit. So this is who we are, and so this slide shows our current organisational structure. So Professor Ewan Wallace is the CEO. We have the Chief Medical Officer and Nursing and Midwifery Officers in the team, soon to be joined by Chief Ambulance and Allied Health. The branch that I lead is Patient Experience and Partnerships, and is listed there first really to, I guess, as a symbol of our commitment to having patients and consumers at the centre of everything we do. And then along there you can see the various other branches that we have. Your more traditional quality and safety support, led by Glenda Gorry, clinical engagement, led by Robin Hudson, Rebecca McTiernan heading up Better Care Victoria, and Genevieve Schreider leading capability and leadership. And we're obviously looking to recruit into the education or evidence and research. And Nicole Brady and Grant are also leading fantastic work from a strategic projects point of view and helping us take the right direction. So our mantra, I guess, is around making sure that all Victorians have outstanding care always. And I think always is the key word there. We were all very familiar with the impact of variability in the system within our health services. Prior to working at Safer Care Victoria, I worked at Western Health, so I'm very familiar with the other side as well, and trying to manage a complex environment with, you know, multiple demands and pulls on the system, and trying to think about how we can make that better. So we aim to do that in a number of ways, and I guess quite simply, we've couched it around 3 key areas. And we're in an interesting time because we are actually learning as we go, and we are listening to feedback as we go. So I do encourage you, as you hear this and you see this with fresh eyes, please give us feedback in terms of where we're heading, because, you know, we're not just set in one way, and we certainly don't think our way is the best way. So we want to work with you and partner with you as well as our community to make sure we shape this for the better. And we've already made one slight change. So at the moment, originally we'd sort of focused on prevention, surveillance and repair. We've actually changed repair to improvement, because I think it gives a much more positive message around how we build resilience in the system and bounce back when things perhaps go wrong, but also share those learnings across the system and with each other for the greater good. So that's essentially how we are crafting our strategy and our work plan. And there's some pieces of work we're already looking at. We've broadly split 4 sort of key pillars, if you like, underneath those 3 areas. So looking at supporting clinicians and leaders to improve the system and in their health services, working with patients, carers and families as part of that improvement process, looking at how better we monitor and use data in the system, so working really strongly with VAHI in terms of what data we have at our fingertips, and I know we've got a long way to go there. So we recently released a revised board report. It's not new data, but how it's been presented is very different. Where we want to get to is ultimately a standalone quality, safety and patient experience prism or monitor, and actually use that for quality improvement and for feedback into the system in terms of how we're going, and ultimately benchmark not only within but with each other and hopefully internationally one day. You know, that's certainly our ambition. And the other part of the improvement is, you know, how can we help you and ourselves when things perhaps do go wrong? So when we see outliers in specific data sets, how do we respond to that? Because it's I think we want to sort of change the conversation, and it's not your problem, it's our problem. So how do we come out and work with you in the sector and actually help unpack that and learn from it, fund innovation, fund improvement, and then scale that across the system. So that's certainly what we're about. The branch that I'm leading, patient experience and partnerships, our job is really to make sure that the patient voice is loud and clear and front and centre of mind. Some of my team are here today. Well, I think we're a bit more scattered today, but I'll give a little wave out to the team, and they're doing a fantastic job. And some of the things that we're looking at is leading by example, so establishing a council for Safer Care Victoria that is purely led by patients and carers, as well as ensuring consumer representation on the various clinical networks and on the Victorian Council. There's a key policy framework that we are about to release, which is around partnering in healthcare, and we're actually going to co-design that with you and with our consumers in terms of what's important and what we need to implement. And I think some of what John will say this afternoon will help shape that and help our thinking. And there's many other ways that we will look at how we use patient experience measures. So how do we improve what we're using the VES for, so the Victorian Health Experience Survey? Can that be enhanced? We've already got 2 years worth of data with the current survey, which is really interesting. So depending on which lens you're looking through, we can actually now start to see 1 or 2 or even 3 key areas. If you focus on those, you'll actually make a real difference to patient experience. So for instance, for adult inpatient, the top 2 were around confidence in your nursing staff, always having confidence in your nursing staff, and the second one was around nurses and doctors working together in their relationship. So if that's an area that you're concerned about, if you focus on those 2 things, you'll start to see a shift in your overall patient satisfaction. Within emergency, no surprise, waiting was an issue, but also it was the communication during that period waiting. So how was I kept informed whilst I was waiting was a very key message in that. And you'll hear a bit from John this afternoon about patient-reported outcome measures, and that's something Safer Care is really committed to exploring and thinking about how we use that either through a network approach or at a system level. So hopefully that gives you a bit of an insight into where we're going, and I'll just sort of show you how that work plan's looking right now. Another important area that I'm keen to progress is how we use patient feedback. And what are we learning? You know, we've got huge data sets between us, so how do we leverage off that and actually put that into action and start making some changes? So I'll leave that there, and I'll move across to introduce John, who's our guest. So John is the Director of Research and the Professor of Healthcare Improvement, Implementation and Evaluation at the Medical Management Centre in the Karolinska Institute in Stockholm, Sweden. And John's work is based on the belief that organisation and management can bring out both the best and the worst in us, and that the right organisation design is critical for effective healthcare. John has many visiting professorial appointments, UCLA in School of Public Health, the Veterans Health Administration Implementation Science Centre in the USA, University of New South Wales, London City University, Erasmus University in the Netherlands. So 35 years of experience, writing many, many publications. I think we got up to about 20 pages of publications when we were reviewing John's history. And really, really proud to have you here with us today, and what a privilege. So welcome, John, to the stage, and look forward to hearing from you.
Sorry about that, Louise. We should have double-checked it. Welcome everyone, and actually I will say a few words by way of introduction. The first is about using the patient feedback that you already get. One of the things I'm going to be talking about is patient-reported outcome measures and learning more specific data from patients about what they value and how they rate your service. So it's worth thinking about, well, actually, do we use the measures that we've already got? And is the reason we don't make more use of those measures, one, because they're less credible or they don't give us good enough information? Or is it that they do give us very useful feedback, but we don't actually have very good ways of linking it in to making improvements, to doing something with it? So I'll raise that question. I think you mentioned the Victoria Health experience approach. Second point about that is that data public? Can I look up my local Victoria hospital and compare with other hospitals like me? I'll just leave that hanging there. And second point is data. There are two things that really struck me about the way forward here. One was the urgent need to be able to collect a wider range of data that are process indicators of quality, but also outcome indicators of quality. And the second thing is to make sure your case mix adjustment is appropriate so that you're making fair comparisons. And those are the two most important things, is to get the right selection of useful quality indicators and to adjust for case mix before you can really use them. And most clinicians, they won't be credible to many clinicians until you do those two things. Now, if you do that, you will discover some horrific variations across the state. And at the moment, you simply don't know. You're flying blind. And that is for me, that would be top priority, to get the IT and to get people working together, looking at what other people have done to choose appropriate and useful indicators of quality in different ways. And I'm not suggesting you don't have anything, but I think that's where the key areas for improvement would be. The second thing that struck me as really important to do is, again, there'll be big variations across the state in people's capacity to make effective improvements, which is to choose. You've only got a limited amount of resources that you can put into improvement work. That's time and effort stolen from everyday patient care. So it has to be used very, very effectively. So you need the data to target those areas and to track whether your efforts are making improvement. But the point I'm making about the capacity is you need to have the skills and the staff and the project management capability to really make the time you do spend on improvement effective. And I think there'd be big differences across the state in your organization's capacity to make those effective improvements, to choose what to focus on and to make sure you do use your time and you have the right skills. And I personally, I'm speaking out of turn here, but I personally think it's very important for Safe Care Victoria to be able to support you to develop your capacity and to fill some of those limitations in capacity in some institutions in different ways. And I think one way to do that is using digital technology, and I'm going to be very, very boring about two things today. One is designing your systems to enable people to give person-centered care, so the organization and design and support systems. And the second thing is digital. We're moving far, far too slow in healthcare into the digital technology. It's transformed other industries. It will transform healthcare. You can already see what is beginning to happen. It's going to be a totally different service in 10 years' time. And we have to get a lot more urgent about investment in IT and managing it to serve patients and staff in the right way rather than being driven by the vendors. So that's a pre-warning of two things that I hope will get really, really boring and banging your heads over the heads about that for the moment. Which takes us to person-centered care. And potentially after, how shall I put it, a difficult period over the last years with inquiries and very nervous politicians, my guess is that's usually how it goes, that you're fairly risk-averse and people are apprehensive and thinking that safer care are the policemen and more inspections. And I think person-centered care is one way, if not the main way, that you can put the emphasis on the positive and to be looking to the future. And if we develop a true person-centered care approach, we will, by definition, avoid and reduce the likelihood of other disasters like that. So I want to look to the positive side and to look at what the gains are for patients with this sort of approach, but also what the gains are for staff in terms of more rewarding care and doing what we went into healthcare for anyway, which was to produce better outcomes and better experiences. Now, all of this is very abstract words, so what I'm hoping to do is give you some steps and tools and ways to see how you can get started to move things into a more patient-centered approach. So I'm not saying, okay, this is the ideal, this is banging you over the heads with how unpatient-centered care your services are. That's not helpful. We need to see, okay, well, that's the general idea. How can we take small steps to move in a more patient-centered direction? And the good news is that you've got a lot of experience and tools and steps that others have taken that you can build on. I'll show you a little bit of the evidence, but I'll be focusing on what are the practical steps that you can take. First of all, though, an example, and I'm going to show you a 84-year-old female with obstructive airways disease and heart disease and mild depression. I'll protect this patient's anonymity by not saying her name, but I will mention the cat's name, Matty, and this is a key part of keeping this woman healthy, and it's the best investment health services can make in care. And essentially, I need to spell out that Mary was able to stay at home and tend to her garden by a combination of her son and the general practitioner and her developing her ability to self-manage and regular checks down at the general practitioner for the heart failure meds and other tests. However, I won't go into the details, but Mary ended up in hospital and was sent home very quickly with no support and MRSA. And this is Mary 6 weeks later after that picture. In this case, you don't need the quality indicators and data. Just the picture tells the story. Tremendous cost to the health system. And what I'd like to ask you is to turn to your colleague and ask them, so what's not patient-centered about that health system? Remember that there wasn't a communication to primary health care. The patient was, by chance, neighbors visited and found her doing badly, and she had to be readmitted within 2 weeks. There wasn't the linking with primary health care. There are also issues in the hospital, change of meds and issues like that. So if I could impose on you just for a minute, what's not patient-centered about that health system, and also could it happen here? Or is that likely to be a kind of a one-off situation? So what does your colleague think?
the online people is if they want to type in any commentary, and we might pick it up at the end.
Okay. Have you got your? You could say that as well. Yes.
I might just make for those who are online, if you want to type in any feedback on that question, please feel free to do so, and we'll pick that up throughout the remainder of the session. But I'll hand back to John.
Thank you very much, Louise. Okay, well, tea's coming up very quickly, so I'm hoping you can keep the conversation going over tea. So I won't ask that, but I will ask, are there likely to be fewer patients like that over the next few years with multiple morbidities and needing fast emergency hospital admission, and you're having to get to grips with that in the hospital? You know the intensity of care is increasing every year in the hospitals. Is there ways that we can reduce the need for those emergency admissions like that? Now, point of the example, well, I don't have to spell out the financial costs, but also the human costs there. The other point is there is no doubt that the individual moments of care that Mary got in the hospital were generally very patient-centered if staff had the time. But it was very much in spite of the way the hospital was organized, and efforts had to be made by staff continually to make those moments patient-centered in spite of the organization. And the results you saw in terms of that picture of Mary, the system was perfectly designed to have that effect. No other effect could have been possible. The way the different bits did or didn't work together, the way there was the information and communications and other support. So it was designed to produce those results. So the thing I want to emphasize is this isn't an individual thing. It's nothing to do with how conscientious or how well-trained you are. There is a bit of that. But most of this is about how your system is organized to support and enable you as clinicians to provide more person-centered care. So the point there is the service structure is designed for medical specialty, acute hospital, visit-based care. And your services are funded and organized in that way. And you struggle to provide for the new profile of needs which are increasing in terms of complex, multiple morbidity and frail older patients. And you don't have the digital systems and the efficiency technologies to be able to respond to that new or changing demand. And staff shortages as well, staff skills issues. So one of the things I'm raising is a certain urgency. I fear that public health care is a bit like the proverbial frog in the pot of water as it begins to get hotter and hotter. And we get more and more used to and accept the challenges and issues and simply concentrate on getting through the day, getting through the next week without disasters. But the changes in the demography, in the demands, continue to heat up, and at some point that is going to boil. And my concern is that public health care will not survive this, and that my concern is that we will see public health care to have been a small blip in history for a short period of time where we had a healthcare system like this for everyone. I think the dangers are is that we end up with a two-tier private and public system, and that the public system we have patients increasing complexity, and the more well-educated and richer patients go to the private systems. We accelerate the inequalities that are beginning to happen. And I say this because I have this fear about the Nordic countries as well and their system. And I think Australia and New Zealand and the Nordic countries, I think the British are already moving in the US direction. And I think there is definitely the danger of that happening here, unless there is much more urgency, and I have to say it also investment, in the right things to get the right changes in public health care. I think our days are numbered unless we get it right. And that would be my general not very cheerful really, but my concern for the future. And on the plus side is I think there are tremendous opportunities, and I think person-centered care is one of the vehicles or ways forward to be able to reorientate and as a basis for the future for public health care, to enable us to be comparable to other service sectors, and to build on some of the strengths that we do have in the public sector. So I think the challenge is to develop transformation structures to help us transition to a new way of providing healthcare, building on examples elsewhere, but also on our sort of values and mission-oriented approach that we have. And I think Safer Care Victoria is part of that transition structure. Let me put it another way. We're only a moment out of the bush, and we are evolutionary wired to deal with the immediate and not so much to give time and attention to building the future. And we're always driven by the immediate urgent issues. And I think it needs Safer Care Victoria and other institutions to protect time and ensure resources are put into building the future, so that it's not just the actual physical buildings, but it's the way we organize care and the data systems and the support for that. And I think those structures and institutions are extremely important. We have to have much more of a sense of urgency, I think, in that area. Okay. Oh, right. John, this is a reminder to John that, John, you're off topic. You're again wittering on about politics and things like that are above your pay grade. Get back to the research and the things. So this is just to show you where we're going. That's the important thing, the tea there at 3:15. So we've got 30 minutes to get you to tea. And what I'm going to do is I'm going to say a little bit more about what I actually mean by person-centered care. I'll touch on some of the evidence. I won't go through a lot of the evidence, but I'll show you reviews of the research and where you can go to for some of the evidence to be putting the case and to look at other people's, what they've done and what they've achieved. After tea, we'll be looking at patient-reported outcome measures, and I hope to say a little bit about implementing and how to actually make our change, and looking at steps that you can take, especially where it reduces costs, because I think some of the changes are not necessarily more expensive, and it's not necessarily about providing concierge or tailored services for each individual patient. And in fact, preview. The issue here is, well, actually, public healthcare, pretty standard, that's what you get. How can we tailor it? On an individual level, we do what we can to tailor it, but there has to be limits to what can be done with the resources available. I think that's one of the challenges that we need to think about and explore. How can we tailor services, make them more individual, when there are limits to the finance and resources available to do that? So, what is patient-centered care? Do patient-reported outcome measures give one way forward? Why I'm profiling patient-reported outcome measures is I think they provide a tangible way that is credible to clinicians for getting feedback about the value that patients place on the services that they receive, and giving us, as it were, a compass or a way of seeing how to move forward. But they also, importantly, allow us to measure the effects of any changes that we make on patients' experience in particular areas. And I'll emphasize again, there's no point doing that unless you have ways to link back into action that we can take to adjust the services to respond to the feedback that we're getting. US Institute of Medicine definition of patient-centered care: providing care that is respectful of and responsive to individual patient preferences, needs and values, and ensuring that patient values guide all clinical decisions. And that's one definition. Remember, most of the American system is private system, and you have to pay a lot for it. And so this is my definition. Meeting an individual's needs and wants as far as is possible with available resources and technology. And it's there that we can make a lot more use of technology. When you think of our life on the internet, using data is one way to tailor services for individuals, and I'll show you some examples of that. But also it's a way to improve the efficiency of a lot of things that we do, and we really need to develop that more. The second part of this is enabling patients to self-care. My point being that 99% of healthcare is provided by ourselves to our family and to ourselves. Occasionally, we need to use health services for help. And we will only do that when it's absolutely necessary for various reasons. So a lot of what healthcare can be doing is paying more attention to actually how we enable and support families and individuals to care for themselves. That's certainly the case with chronic illnesses, but also in terms of leaving hospital to maintain and recuperate. So what we need to form more partnerships with carers, and it's not just for children, it's for everyone. But as wanted and appropriate, including informal carers. So sometimes we do not want to self-care, we're not able to self-care, we actually want someone to take over, we just can't, I now need someone to take this on board and help me here. So it is about a flexible response and understanding when people want and able to take on more of their self-care. And I think we're not very good at recognizing and responding to that. And there are big differences amongst people, but also big differences at different times in the illness episode to be able to do that. But one of the keys is that we design our work organization, our systems, to achieve these things. And at the moment, they're not well designed to support this way of responding to patients and to informal carers' needs. So that's one definition. Like I was saying, one of the big advantages is there is some material out there that's tremendously helpful. One of these is the British organisation, the Health Foundation. About 5 years ago, they started quite a large program on patient or person-centred care and patient involvement in safety and healthcare. And there are a number of excellent publications on the Health Foundation website. This is from one of them in 2014. It's a scan of the literature on the subject. And they break it down. Some of these are clusters of areas and research, shared decision-making that some of you may have heard of. Some of that is to do with providing patients with information, videos about the pros and cons, for example, of watchful waiting versus treatment, so that they can opt for different treatments, being fully informed of the issues. And there are a number of shared decision-making tools, long-term care, chronic illness, self-management support, but also peer groups, peer education, extremely powerful method there. The aim here is to give knowledge, skills, and confidence to manage their condition effectively, so that we need to support people to do that rather than do it for them. And care support and planning is about jointly assessing and planning the objectives of treatment in particular ways. Now, what it's got here is involving people in their health and healthcare. And I still think that's a bit around the wrong way. We're not involving people in their healthcare. They, in their desperation, have turned to us to involve us in their healthcare and help them. So we aren't deigning to involve them in their health and healthcare. It's round the wrong way. And that goes into an agreed and personalised plan. This doesn't mean a guarantee that we will deliver everything in the plan, but we need to know what's there and have that documented so that we can see where the gaps are and to build up evidence of what's needed. This is a way of spelling out some dimensions of this that I think are important. Here we're talking about the individual patient. You know, I was talking about moments of person and patient-centered care, moments where you get that, where you get a really nice receptionist or a nurse that is just a knockout for that moment. Individual patient and then groups of patient. And this is all about organizing in systems for a number of patients with that condition or a number of patients that will need that procedure. And what this does is it's slightly, banging you over the head with an extreme view, but to make the point, to make the contrast. Provider-centered care for the individual is, well, look, come to where we work, we give you access to the tests and treatments that we think you need. You depend on us for your appointments and furthermore, we own your data. It's our data, and you can't see it, and we own it. And by the way, there are laws that restrict our ability to provide it. Now, for the contrast here is patient-centered care is patient self-care is our starting assumption. Our starting assumption is, well, actually, they've been caring for their health, or maybe miscaring for their health, before and after they see us for a short moment. So we have been invited into their lives by themselves, as it were, to see. They're inviting us to say, well, okay, what can you offer me? Now, in some cases, when you're out flat after a traffic accident, it's not quite like that. But in many situations, it's self-care should be the starting gun. And then the issue is, what is their current health condition preventing them from achieving in their life goals? Whose wedding or school play are they not able to get to because of their health condition? So what are their goals? What is the life activities that they value? And we do a needs and asset assessment. And what are their assets that they can draw on to do that, and plan the goals? Now, this is all fairly new, apart from, for example, in mental health services. I think some cancer centres move in that direction. And then the aim is, well, what we need to do is augment what patients can do for themselves with tests, treatments, and access to information about what works for other patients like them. Now, that's very different from how we think of healthcare. And what it is doing is it's kind of bracketing or framing medical tests and treatments within a particular way of operating. And you can see the change in attitude, but here, a change in organisation that would be needed to move more in that direction. And sometimes it's actually not appropriate to go too far. For some patients, that may not be appropriate. But for a lot of patients, that may be one way to go. Now, you can only do that if you've designed a clear path for most patients with those sorts of needs, that you've organised things to support that way of working for individual moments of care. So at the moment, what we've got is organised by departments. You move the patient between the departments. The departments give a standard product, and its medical specialties, physical visits, come to us. We'll put you through the system and pass you between different places, and they'll all give you their standard product. We need to think more about the pathways that groups of patients like that move through, and design those pathways, and our information systems and organisation of staff need to be around those pathways. And then, so it's the work roles and the systems feed into that pathway. And then the issue is, what variation are we allowed or able to make within that general pathway? Because, I mean, it is a bit like a path in the bush, that without a path, you just got a compass and you try and make your way through it. If there is some sort of pathway, that makes it a lot easier to go through there, but you need side pathways off it for different things. So this is again touching on that issue about variation and how to tailor for individuals as appropriate within an organised system. That's the challenge there on that kind of thing. So the main point I'm making is, staff cannot give more patient-centred care unless there is some organisation and supports that enable them to do it. And at the moment, the workload, the throughput, the way we do it, prevent staff from being more patient-centred. So it's not about training people to be polite, and it's also about getting the organisation and data and systems arranged in that way. Okay, one of the tools. Has anyone heard of the Plane Tree organisation? Yes, we've got. In fact, I must ask, how many people here spend more than a day a week seeing patients? Okay, thank you. Somehow I expected more clinicians, but maybe not everyone's putting their hand up, or active clinicians. Actually, may I also ask, how many people here are with or from patients' organisations, patients' representatives? So we've got one, thank you. So we've got, okay. Oh, actually, there are a few. Thanks. Thank you. So I'll call this a tool, and this is also a way of, it's basically an assessment system so that you can assess your own organisation for how patient-centred it is according to this US organisation's conception of patient-centeredness. So it makes those, the definitions and the philosophy tangible and measurable, and you can assess. So there are 10 areas, and you rate. It's a bit like, in some ways, a very simple accreditation system with standards. This practice fully implemented, this practice partially, no activity, or it's not applicable. And you can download that from Plane Tree, and this gives you an idea of the different areas, and this is one of the standards. Personalisation of care. Patients are able to make requests for when meals will be served to accommodate their personal schedule and routine. Now, remember, American healthcare is a business. There's no two ways about that. It's even the not-for-profits, they're making money, and they have to keep their eye on that. Public healthcare, again, we hit that issue about, well, just a minute, how much can we kind of accommodate or tailor to individual patients, given our budgets, given our staffing? And I'll just make that blaringly obvious point that we will need to keep coming back to this, what's possible in public healthcare. I think one of the points I'm saying is unless we really make efforts on that, there will not be public healthcare in 5 to 10 years' time when you look at the gaps that are developing. So those of you who want to give this one a go, is page 9 of that particular tool that you can download the PDF from on that. Now this is interesting. In fact, I was too late to use it for my mother. It's COPD. It's the British Lung Foundation. And one of the things the British do is they have a thing called a patient's passport. And it really is very, very simple. It's a document that simply, it's a bit like, I don't know, do you have these standard legal documents where you can write your own will? You fill in, it's a lot less expensive, isn't it? I just hope it works. I won't be here to see the fight about. In fact, I'll take it with me, so there won't be one. So, in fact, the fight will be about who's going to pay his debts. But anyway, it's one of those standard templates where it asks you to put statements about your needs and things to consider. It's really that simple, and it can be scanned and put into electronic medical record or recorded. But you take that with you in visits, encounters, certainly in hospital issues. This one is for COPD, and what it simply says, it's a web one, you can look it up, British Lung Foundation, COPD patient passport, and you just simply go through it. I would have had to step my mother through this. Choose yes or no statements about your care. At the end, you'll get a personalised passport, so you go things about do you know how to use your inhaler? Some very simple things like that. And do you need, have you been taught about this or that? And then you get a printout that simply says, in response to your questions, okay, these are things you need to talk to your doctor and nurse about. And then you fill in the other bits about basics. So you take that with you as one way to do that. And there are a number of these passport versions in the British use. So that's a very simple approach. All right, more tools later, but I'm going to raise this, given the time, and it's tea time shortly. Rhetorical questions. What are the prospects? Will care become more patient-centered for people without a home? For people in the last months of life? That's a very important thing. Are there alternatives to the ICU? People who cannot speak English. Anyone who has money to spend on it. And the point that I'm raising here is, as public services, we need to, it's our duty to ensure that care is patient-centered for the voiceless and vulnerable, and for those who are less vociferous about getting the services that they think they demand and need. It's those people who are not accustomed to asking and asserting themselves as public services. We need to pay attention to those and make sure that those people also get their fair dues. So I'll leave that hanging and raise some of these obvious issues that we can come back to. So, individualized care, is it only for those who shout the loudest? Are there effective ways to mass customize healthcare? And this is this point about tailoring within an organized system. Where can we give more and be more responsive to the individual? I think one of the things is equal access is one of the things that's very clear to me in Sweden is one of the things people insist on and respond to is when they need you and when they finally get around to calling you, they want a quick response and a quick answer to that, an effective answer. It's later on when they get into the system that people are prepared to accept that there may be people with greater needs. I mean, the obvious is the emergency department scenario. You know, one of your children has fallen over, grazed their knee. You go in there. Yes, it's mayhem, but so long as you get logged and register and you're into the system, you're okay to wait, because there are people who are much worse off than you in line. And I have noticed in this country, you're very good with the British forming queues and, you know, what is it? Come on, mate, there's a queue here. Isn't that how you know, there's a line here, and you get pretty quickly organized into what's fair dues. So the distinction I'm making is between first contact, response, logged, and okay, so long as I know you're on the job and you've got it, then okay, I'll wait my turn or recognize that there is, I suppose you call it fair dues here in that. So I think that's important. Second thing is getting a quick matching of the person's need to the particular service that can respond to them. A lot of this has got to do with your first telephone call, ED, how that front end is organized. And I think that's that's the crucial bit to get right for patient-centered care is to have an effective and good response to that. Out-of-hours care is one issue there. So I think people will weight that, and that we have a duty to manage the vociferous to allow for the voiceless. Okay. Louise, can I do this before we break? Yeah, and then we'll go for tea. So I'm hoping this link will work on my workaround. So test your Swedish here.
Vid länssjukhuset Rheumatoid i Jönköping har det funnits en självdialysenhet sedan flera år. Men i våras invigdes en ny paviljong med 12 platser, 8 fler än tidigare. Just nu är det 14 patienter och de nyttjar platserna enligt ett schema.
Ibland kommer jag klockan 6 och då öppnar jag med kort och då är jag helt själv här. För att personalen börjar inte från klockan 7. Och vi som har kort, det är vi som sköter oss helt själva.
Paviljongen kom ju till nu i april har vi invigt det. Och tidigare har vi försökt att få att dialysen ska utvidgas. Men så har det inte funnits pengar och resurser. Och då känner man, nej, inte nu igen. Men nu när det här är klart så känns det som att det var rätt timing. För det är nu vi har börjat mer tänka självdialys, att de flesta ska kunna det. Innan var det nog att det hade blivit som en vanlig dialys och så har man kanske tagit ett hörn.
Det första jag gör när jag kommer på morgonen är att jag startar maskinen så att den gör sitt självtest. Sen tar jag min vagn och går ut och hämtar mina grejer. Efter det så börjar jag klä maskinen och sätter dit slangar och filter och lite annat. 20 minuter för att bli färdigt allt sammans innan jag kan börja sticka nålarna. Jag sköter alla momenten från början till slut helt själv. Själva dialysen tar ju 4 timmar när jag är kopplad i maskinen. Sen ska man koppla innan och man ska städa efteråt. Ja, 25 timmar i veckan ungefär.
Normalt så styr ju dialysen livet, för du har måndag, onsdag, fredag kanske klockan och så är det det. Men vi skulle vilja att livet styr dialysen. Så att om du behöver lämna barnen eller du behöver hämta dem eller du jobbar så ska du komma efter där. För du måste ha dialys. Men du kan försöka få det att anpassas till dagen som du har det.
Hemdialys är ju inget alternativ för mig. För att jag bor i hyreslägenhet och har lite utrymmesbrist. Jag är ju här 4 dagar i veckan och trivs jättebra här. I väntan på att få en njure då så funkar det här jättebra. Som sagt man får ju många nya vänner också. Så.
Det är inte bara kanske att köra sin dialys utan du måste veta lite också vad det innebär. Jag vill gärna att man förhoppningsvis lär dem lite och hur man tänker. Och det känner man att de gör. Och sen börjar om jag gör så här. Och då känner man, ja, det är ju det man vill. Att de ska känna som att de är medverkan, inte bara i maskinen utan att det ger att de är i hela sin situation.
Läkaren kommer och sjuksköterskan kommer som du har då, så diskuterar man tillsammans hur man ska lösa problemen. Och det är ju bättre, det är ingen som pratar över huvudet på en här, utan här är man helt insatt i vad som ska hända. Och jag kanske har idéer hur jag tycker och de har idéer hur de tycker. Och så löser vi det tillsammans. Och det är en fördel. I och med att sjukdomen tar ju ganska mycket del av mitt liv, så då är det bra att vara väl insatt.
Och just att vi jobbar ihop, det är så härligt. Jag tror när vi började med paviljongen, då var maskinerna var nya för oss också och för patienterna till exempel. Då var vi exakt i samma nivå. Vi satt med manualen båda. Och ingen var bättre än den andra. Och det var så här, och man kände lite hur de steg så att, och det tror jag är viktigt. Jag är ute en del och föreläser och då hör man liksom att varför lyckas ni så bra? Och det är för mycket av vi har inte så många måsten. En del, du måste göra så här för att göra, till exempel du måste gå 4 dagar i veckan för att komma in på en självdialys. Och har du då gått 3 dagar i veckan, tycker det är mycket, då backar man. Men så här är det tvärtom, de kanske är vana vid 3 dagar i veckan och kommer in hit och så mår man inte så jättebra. Nej, så man kan antingen öka tiden eller dagarna. Och så ser den och de andra säger, men vi gör 4 dagar, det är jättebra, vi mår mycket bättre efter det. Då har du ju någon i samma situation. Det är mycket lättare att ta åt sig det än att jag säger det. Alla tänker ju ekonomiskt och det gör ju även vi. Och det är ju det vi har gått ut med också, att det ska inte krävas så mycket personal. Vi tar mer insikt om förrådet, även med läkemedel. För normalt är det ju chefen som kommer att aj, nu ska vi spara och det ska inte gå åt några pengar. Jag tror det är bättre att om vi får den insikten. Och det är inte kompresser vi sparar på utan det är liksom sättet att tänka. Och då har ju även där patienter som kommer med små bra idéer. Tillsammans så blir vi starka och kan utveckla vården kanske på ett helt annat sätt. Så om 10 år så ser det annorlunda ut för att vi har en patientmedverkan. Och den är fantastisk att följa.
Could I just say 10 seconds? Just some quick things. Yes, we couldn't do that with every patient, but the starting point was more self-management, and then we adjust, obviously, for different patients' needs. The other thing is, you remember what you heard Britt-Marie was saying about, well, actually, it's better if other patients say, well, maybe you need to come more often, because it certainly helped me moving from 3 to 4 days. So the peer part of that is an important component.
Thank you, John. We'll take a break there. So we'll make it 20 minutes and we'll catch up time in the next session. So please go and help yourself to some tea, coffee and some light refreshments. And if we can regroup at 3:40. So welcome back to those online. And when you've grabbed your coffees, just feel free to come sit down. Those at the table, I'll just get you to close your conversations just now. And I'll attract our speaker back to the audience. That's your hint, John. Back over to you, John.
Thank you very much. All right, okay. Thank you. I think it's probably the wrong time of day to take you through the research evidence, but I'll do it very quickly and show you where to go if you want more of that, because there have been a number of useful reviews of research, which is always the first place to start to look for the evidence. To point out the needs, here's just one very simple study. It's a bit old. It's also Northeast USA 2009. 53 patients, rich, white women, Northeast USA. 62 doctors, 70% of them female. What we're looking at here is patients with breast cancer, and to the question, what's the most important consideration, goal of surgery, keeping the breast. Patients reported, 7% of patients reported that was the most important consideration. Doctors, and remember this is women doctors, 71%, which is quite interesting as the most important consideration. To the question, do what your doctors think is best, 86% of patients said yes, I do what the doctors think is best. Doctors thought 14% would say that. So this is one of a number of studies that show really big differences between what patients want and say and what doctors and nurses think patients want and say. in a number of areas. Now, the research evidence breaks down into two areas. First of all, problems about patient-centered care. I keep saying patient-centered care. I should be saying person-centered care to underline the point. So we're not short of data about adverse events. Under communication is one of the biggest areas. Classics to do with medication errors, people not being told about medication side effects, and so on. I do not like this one, ignored advance directives, when people have said very, very clearly and provided a written advance directive that preference about extra care, resuscitation and so on hasn't been followed. Also, data breaches. We need to recognize that unauthorized access to your health data can be very harmful to you in a number of different ways and is a safety issue. And that is a very important thing to consider in terms of unpatient-centered care, the management of patient data, the protection of patient data, but also issues about access to and ownership is one area. Now, the evidence of effective solutions, what to do to make care more person-centered, is limited. Let's say there's more experiential evidence. There are your peers, doctors and nurses, reporting schemes with some evidence of the effectiveness, but there's not many rigorous studies that have looked at and compared patient-centered organization and services with the alternative. There is some, but it's only in particular fields in certain areas. So looking at those reviews would be a way to track that down if you have to make a case or an argument and to draw on the evidence, especially for the business case. So there are some interventions about improving access, a lot about care planning, and improving the responsiveness of the services. As regards this area that I've highlighted about better design for consistent patient-centered care for a patient group, we need to turn to some of the work on pathway redesign when we've picked out groups of patients and we've reoriented and designed pathways or critical patient paths that have been supported by data. So there is some data on some of that re-engineering or flow research. So to summarize, Angela Coulter is, I think, really the best person on this subject. Anything Angela has written, you can understand it, and she pays attention to evidence as well, but also gets to the main point. So Angela's done a number of reviews. This is in the BMJ, and this shows you some of the areas that she's looked at: health literacy, clinical decision-making, improving self-care, improving patient safety. And there is a whole literature about how to involve patients in patient safety, and a little bit of evidence about the effectiveness of patient involvement in safety issues, both at the sort of the group level, but at the individual level, what patients can do for themselves in that area. So what this is showing is simply the reviews of research, and in each review there are different types of research, from observational to interventional, and this shows you, just gives you some idea about, for example, 5 negative for that area. effect on patients' experience, effect on use of health services, which is related to the cost things, and effects on health behaviour and health state. So that just gives you a quick picture of what's there, and you can look for your particular service in, that's one way into what the research says. I've done a series of reviews about return on investment and looking at how much do you have to spend, how much do you save, and over which time scale do you break even on what you've spent on those improvements. And some of the interventions that could be argued to be patient-centered is dosing issues. Decision aids is an important area where you have videos or information which enable people to make better informed decisions about which treatment or whether watchful waiting, and to be much more clued in about what the benefits and side effects of different treatments are. And that, given the short time we have in consultations, you need to assume that patients will walk out of the room not being able to restate very much about what they heard. So those information, when they get home and they're a bit clear about what's going on, and in their own time and own pace, can look up packaged information which is understandable and designed for patients to learn about the options and to take a greater role. Some end-of-life home-based care is extremely cost-effective, and also various interventions to improve participation. Patient-directed coaching, educational materials, some of those. Those are a few of the sort of no-brainer, best-buy, patient-centered. One area, certainly in the States, there's a lot on this, is care transitions. People leaving hospital, and there are 8 different models to enable people to return home with support and to provide input and help to them so that they don't end up being readmitted like my mother did in that situation. And there's some very good evidence of these and a lot of reports and work on this. One reason being in the States, if you readmit, if it's an unscheduled readmission within 30 days, the hospital is penalised and it's financially an issue. So it's now more cost effective for the hospital to pay attention to educating, phoning people up at home, checking that they're okay, even sending people to the homes of certain patients to make sure they're all right. The hospital doing that. Now, I know you might say, well, actually, it's just proper handover to primary health care to take it up. But in these instances in the US with, how shall I put it, varied primary health care, the hospital just takes it on board to do this outreach and enable transitions. So there are some models and ideas there. The point is that things go wrong when patients move between services. The problems are in the in-between. So most of these use education and coaching, and these are some of the costings that's been done on that, on rehospitalization. So to summarize very quickly, Angela Coulter's work, anything Angela does is worth reading. There's patient-centered care and outcomes, systematic review and medical care research review. The Health Foundation, person-centered care from ideas to action, that's a very good summary and scan, and more recent. WHO have got one as well. This is another recent one about involving patients improving safety. So that's some of the literature, and the Victoria Safety folks that Louise and colleagues represent has some of those. Now, where I'm going now, very quickly, is to turn to patient-reported outcome measures and to show you some examples of that. The reason being is that I'm going to suggest to you that some patient-reported outcome measures are a tangible way in which you can take steps towards more patient-centered care, and it begins to give you data, and it's credible to more clinicians to use these approaches. I also will alert you to this statement last month, Health Ministers OECD statement by Health Ministers agreed a program of work to assess whether health systems deliver what matters most to people, including using a common set of indicators to measure the outcomes that patients judge the most important. So they've agreed that the different health ministers' countries will move towards using these kinds of measurement systems to show what patients value as an important way forward. So, okay, so does anyone here do jogging or running or whatever you call it? We've got one. You know, this is shocking. I I suppose you all smoke as well, don't you? I mean, I'm constantly surprised by this. Okay, well, I was confronted by this picture, and I also had an orthopedic surgeon pointing to this up here, saying, well, that's why it hurts, John. In fact, I'm surprised you were able to walk in this room in the way that you did. But very brightly, he followed that very quickly with and we can do something about it, in a very sort of pleased, cheerful attitude. And it is hip replacement is one of those areas where there actually is a very quick improvement. I was really surprised how effective and good it was. So I had it done at what's called a focus factory. All they do are hips and knees, hundreds of them. Chose this outfit because it was near where I lived, actually near Arlanda at Stockholm Airport. So I was a traitor to the Karolinska. I took my custom up there. But I could see from the data, because we have a national quality registries, we have 108 disease or procedure national registers. I could see from this that they had very, very low complications, very, very low reoperations, and the data was good. So it was a bit of a no-brainer that was the place to go. And they were brilliant, absolutely brilliant. It was a bit quick. I had to leave earlier than I really would have liked to. But they had to do this hip replacement on, he said, actually we get paid $5,600 US for the hip replacement, which is phenomenally low cost. There is a choice, well, I won't go into the details of this, but one of the points is we are moving to a bundle episode of care payment system where the actual operation that they do will be put together with rehabilitation and the pre-op work that can be done elsewhere or done by them. And the idea is to give financial incentives for them to coordinate and cooperate closely with other services to provide a package of care so that the financing is aligned to support those pathway kind of approaches. And there are a number of experiments and people are moving towards that more value-based funding episode of care. You can do it with some procedures or some diseases, but not every. I mean, cataracts and other ones that we're doing that with. But the point I'm making here, where I'm telling you about this, is that it's a very simple patient-reported outcome. Every 6 months, I have to put my mark on the temperature, this is any pain, and this is any complications. And that was my absolutely knocked out judgment of their work, and I do that every 6 months. So that goes into the National Hip Registry. So it's a national database. It's got demographics on each patient. You can see how old I was, where I came from, what sort of job I had, what the prosthesis was, the particular implant that they used, the cement that they used, the particular type of procedure that they used. And then I report regularly any outcomes that I do or don't value, and there are other data that they can link it to. So what I'm trying to say here is that the patient-reported outcome measures are part of a larger database and registry, and this registry is incredibly important for both for short term, for giving physicians feedback on each of their operations or how well the unit is doing. So you can see outcomes per cost. You can actually see the value added by that unit per patient. Case mix adjusted, very good case mix, which is extremely important. So I was a really simple case in terms of comorbidities and age and things like that. But my mother, who fell over and broke her hip and ended up in hospital, more complex case, 24 years older. So the expected, you can predict the expected outcomes from those kind of data. And that's how most case mix goes, is age, comorbidity, and other basic factors. You can predict the expected and compare the expected with the actual, so that you have fair comparisons between hospitals on case mix. That's one of the challenges here. One of the big data issues here is to be able to make those fair comparisons. Medium term, it's for quality improvement projects. So one of the things we're doing is putting a lot more time and money into training staff to be able to use the registries to track any effects of the changes that they make to the organisation of care, any improvements that they do. And you need timely data. So if it's longer than about 3 months old, or certainly 6 months, it's less and less credible and useful. And you can't attribute outcomes to the actual quality improvement change in that way unless you do that. But also the long term, what was significant about this is when you have 40 years of hip replacements logged, ever since the registry started, the presentations at the annual orthopedic surgeons meeting, people were able to see, to begin with, the actual unit, but then the individual physician anonymously could see your outcomes compared to the others, case mix adjusted. And you could immediately see which implants, which prostheses you needed more reoperations. So over a period of time, I think it was 10 to 15 years, the Swedish orthopedic surgeons converged on, I would say 80% of them are 6 or 7 particular standard implants that the country started buying more and more volume of, because these had a very long lasting. And what was clear is those implants where you needed reoperation, because the actual prosthesis was just not faulty, which is why that orthopedic surgeon was able to say, and what's more, it'll last longer than you will, my boy. He was able to give a over 20-year life. And actually, I mean, that's the thing. At 80, 84, I don't want to have a reoperation. It's not plain sailing, this thing. So the long-lasting, actually, I'm all in favour of that, as well as the cost side. Now I'm going to show you another example. This is the Rheumatoid Arthritis Registry. It's what I call a smart registry. And like the Hip Registry, patients report in this case, we've got a tablet that you can use over the internet, and the patient reports the disease. We use the patient reports of soreness and pain in different joints that they fill in to calculate the disease activity score. And this is a standard score that is used to track what treatments, how the treatments are affecting the rheumatoid arthritis. There was a big revolution around the year 2000 with biologic drugs for rheumatoid arthritis. They're extremely effective. One of the issues actually is starting the treatment early. It reduces the deterioration. But they're very, very difficult to get the right. There are a number of different drugs that can be used, and the right combination and the right dose is very trial and error. It's astonishingly crude. This system makes it a lot quicker to zero in on which medication is working, because you can track it against the patient-reported outcomes, and to see how that works. And you'll see in this video how they were able to do that. So again, we've got a quick trip to Sweden, but you'll be pleased to hear that this time it's in English. And we've got
I have several hobbies, singing in choir, traveling, but most of all I like the gardening, and the garden is my pride and joy. My disease started 25 years ago with pain in the hand and the feet. I tried to ignore it because I'm a doctor myself, but eventually I have to go to a colleague that give me the diagnosis rheumatism. My disease has been quite severe, so I have had the strongest drugs from the beginning. It was a new life that began. Unfortunately, it didn't last. It has been ups and downs over the years, but still it's much better after the new biological medicines. They are more effective, but still I have to change between drugs, and now I'm on my 4th biological drug. Nowadays I work together with my doctor and the computer for every change in the treatment. I can check my chronic disease at home in between visits. Before I go to see my doctor, I measure my own health. It's easy, I just click on the screen and enter how I feel now.
More and more doctors use national measures from the registry. Today, 25,000 visits per year are reported directly from the clinic to the quality register in rheumatology. When Karin visits me at the clinic, I access the information that she has entered at home. The quality registry uses nationally agreed outcome measures. I can also compare my results with other clinics and also with the best in Sweden. I have invited Karin to use these measures, and she gives me information on how she's doing and the effects and the side effects of the medication.
The internet support system enables me to contribute the management of my own disease. I can monitor the effects of the drugs, how they help me and if they failed. I can better understand my doctor's reasoning when we decide on my medication and how I should take it to get the best result. Now I'm doing fairly well, but we can see together when the disease becomes more active and I need a new drug.
The new drugs are so expensive that there are always questions about the rising costs. I feel confident that the drugs are used in the best way, since I can measure the effects all the time in every patient and at every visit.
Now I have a system to help me take control over the situation. I can use it to compare how it is now and how it has been before. The other day I told my husband I've never been as bad in my disease, but he didn't agree. And we looked together on the data at the internet and realized that I've been worse before. This helps me get through bad periods by myself, since I know I've managed it before. The future is bright. Here in the spring the garden is wonderful and I can work in it. We are soon leaving for a 3-month trip through Europe, and that is a dream of our life. And that hasn't been possible before the new medication.
So I need to finish off, but you've got the handouts, the PowerPoints, and I'll just mention a few. There are 2 types of patient-reported outcomes: more generic scores, health-related quality of life, and some which are designed specifically for different diseases, like, for example, the arthritis one. In fact, there are 800 or so of these patient-reported outcome measures that have been developed for different patient groups, and actually some very good pediatric patient-reported outcome measures as well for children and also parents. The disease procedure specific are more credible and more useful, but you need to be able to link it to action. Now, that's Angela's definition of patient-reported outcome. You've got that in your handouts, so I won't dwell on that. Angela did a very, very good summary earlier on this year. I think it's February. Yeah, 17th February. That's to remind you about disease-specific and generic. This is one disease-specific used in mental health for depression. One of the issues is to make it easy for a range of patients with different understanding, health or even general literacy to be able to fill in. That's one of the issues, and that's true for the administration. Multiple morbidity patients, well, there is Kelly has developed one for a number of different diseases for those. This illustrates the importance of having it over time. So for prostate cancer treatment, they use patient-reported outcomes in this instance. Baseline, 6 months post-radiation, 2-year, 3-year, and you can track that over time. So this is to say, well, actually, some of these problems have not involved patients in developing them. And this is to say, well, one set that has been developed for international use is the ICHOM. And if you look up ICHOM, you'd be able to see some of those. And what it shows here is the patient's perspective, the provider's perspective, and also the registry perspective for research purposes. And they develop in a consensus process like that, a comprehensive set, and then a minimum set. And there are a number of these for example, we've got different cancers here: stroke, frail elderly is an important one, recently developed colon cancer, and some cardiology. So that's a useful starting point. Now, safer care Victoria is looking at this particular approach as well. It's also, I think, quite useful because it's designed to be used with a variety of different information technology systems. So it doesn't need very sophisticated systems. I'm going to, no, I need to finish off there. I've told you about the proms. On the last thing I'll say is some of the options. Well, paper and electronic, you have to go electronic to the burden of data collection and the way to analyze. Frankly, I wouldn't do it unless you do it electronically in different ways. One option is the hospital is responsible and reports to a registry database. The other option is that the registry is responsible and the hospital tells early. But usually we do a mix where the hospital collects the first patient-reported outcome and then the registry does the follow-ups. And there are issues there to make the data available within the electronic health record so the clinician can see the patient reports of the particular issues and how it tracks over time. So I think I need to, those are design issues and there is more in the handouts. Start with where one has been developed. The PROMIS database has 3 sets of patient-reported outcomes and you could start off checking that particular website. So I'll stop there. Louise,
can we pop this?
Gone
Thank you.
over time a bit.
Thank you, John. And I'm sorry, there is never enough time, is there? So apologies, but I'm really keen to give the audience an opportunity to ask some questions. I might just check in with my colleagues in the corner. Is there anything come through online as such yet? So I invite those of you who are listening online, if you want to send any questions through, now's a good time to do so. But I'll open it up to the room whilst we've got John with us for some questions, and we'll have our active members go across with their mic. And this is good for your steps, James. We're doing Step Safari this month. So we're all competing with each other to do as many steps as possible. Hi.
Hi there, my name is Ben Slater. I'm really interested, I love the kind of apps and things that you've shown and demonstrated. I just wonder if it does introduce another level of discrimination in the process whereby people who are not computer literate, who are probably are at a loss because of this, and those of us who are well educated and can use computers well are better off.
Yeah, I think that is an important point. Both in developing, you know, if it's a paper patient-reported outcome measure, developing that in language which is understandable to people who may not have English as a first language, you may have to do those translations. And then to make sure that it's presented in a way in which most people would interpret it in the same way to get reasonable standardization. And that's where all the development work comes in. And if you look at the PROMIS database and some of the problems that have been developed, that would be an important thing to look into, to look at the population for which it was developed and how similar and different it is. Because I know, certainly in Stockholm, we've got a number of immigrant groups. And I know you have recent immigrants and people who may not have English as a first language, or the whole issue of literacy. So in some situations, you may need a coach or a helper to fill that in for the person. And then if you add the computer reporting, if you have a tablet, then it has to be very simple, like that tablet where you just push on or you use a temperature scheme. But I think the work of developing ways in which people are able to articulate their views using visual, smiles, temperature, there's been a lot of good work done on that. But you will always get a biased sample And the important thing is to know what the bias is and which people may not be reporting, to be aware of that. I think that's an important point.
I think another important point on that, if I may add, is that we can't make any assumptions there either. So, indeed, there are some groups who surprisingly use digital technology and social media a lot more than we probably realise. So, I mean, I think we have to consider it, but we also need to ask the question as well, which is, something I've not always thought about. So, thank you for that question. Any other questions from the audience? So, John, I'm interested that you talked about using the digital platform. Any advice for people in the room who are thinking about using proms other than what you've mentioned already? I mean, where would you start?
Well, I would look up the PROMIS database. They're not all in there, but the PROMIS database is run by a US agency to be publicly available. So what you will see in there are those that are publicly available and you can download. And it's got useful resource material. So that's one way to go. I think it's important to look at your specialty or the particular patients that you're serving. And in your journals, over the last 5 years, there'll be more and more reports about, so just searching in the journals that you're familiar with within your specialty or patient group for a patient-reported outcome or patient-reported outcome measures, you would find something in that journal, or just Googling on Google Scholar or PubMed, you'd be able to track them down. And then you can look at how suitable they are for your population. Now, the advantage of using one that's already developed is you might be able to compare with them some of the scores which they get, and also that it's been developed and validated. So, there are pros and cons about changing it for your particular group. But the plus from where you're starting is, well, a lot of work, all the development work has already been done, and you can build on what other people have been doing.
So we've got a question at the back table there. Can we just wait till you... Thank you. And if you can say your name and where you're from, would be great. Thank you.
Dominique Cadillac from Monash University and the Florey. I'm a data custodian for the Australian Stroke Clinical Registry, and that has emerged outside of funding from government, though it is now being supported within Victoria and Queensland and a few other jurisdictions. It's very hard to get support for funding for clinical registries to do a comprehensive approach, as has been described. How did that come about in Sweden? I'm so impressed. You have 108 clinical quality registries and a strong history of that. How do we convince our governments of the return on investment? And, I think as we have federal and state government responsibilities for different things too, how do we get more partnerships around that? Because I think that's one of the things we struggle with here, and keeps us sort of behind the 8 ball internationally.
Yes, thanks, but I think the States is, don't assume that, for example, the States has got this fixed, because I think they may be even further behind than you are, frankly, in many areas. There are a number of important things to be aware of about how they were able to do this in Sweden. Number one, these were developed by clinicians and clinician researchers, most of them initially for research purposes. And you needed leaders of each specialty and respected researchers to sell it to clinicians to find ways to put the data in. So many of these were started before electronic health records, and it was manual data entry, and they weren't terribly useful to clinicians. So a lot of it was, well, okay, we'll do this for our research colleagues kind of thing. and we've got our people who own and run it in the department at the Sahlgrenska or Karolinska or Uppsala. So it was owned, developed and run by medical researchers with the buy-in of everyday clinicians. Then I think and it was financed in one level by the national government, but mostly financed by each hospital giving time to allow the data input and to send, in the old days by paper, to the national agreed centre for them to input. The step change came around 2005 when more and more of them were changing electronic medical records to include additional data entry points for the register. And that really began to reduce the burden of data entry, and it increased the speed with which it could be reported to the national database. And then when the national registries then made available online much more timely data, then the data became much more useful to each department for their quality improvement or other purposes. And some of the registries put quite a lot of work in developing software and reporting to make it useful for everyday operations reporting. So that was a key thing. Now, another part of the funding was its law in Sweden to have, for each drug introduced, funded under the government system, you have to have a way of reporting adverse events or side effects for clinicians to register and report that. So quite a few of the registries went to the drugs companies and said, look, you can use our registry as a way to meet your legal requirements for adverse drug event reporting, because that would be part of the registry. And that was part of the funding that went for the registries. The final thing was a report. The government in 2010, I think it was, invited the Boston Consulting Group to do a review of the registries in Sweden. And this report, which is online and available, said essentially, look at the value you're getting from these registries, both for your medical research program, but also how they can be used for quality improvement, a whole variety of different things. And by the way, you know better than us that genomics is coming and how important it will be to link these registries to the biobank and the genomic profiling and what you can then do with that. And the government was persuaded, sort of, whoa, this is a big, we can get a tremendous return on investment if we, initial reservations about giving the doctors more money for their own pet projects, it changed the view to see, oh, actually, this is really important for Sweden's medical health industry and for the direction we're moving, given the genomic research that we're already developing. So the government increased considerably the funding, but it kind of came with it. I don't think all the docs were aware of this, because there's always strings attached, and with that government funding came the right, certainly for researchers like myself in some of the research, we have right of access to these registries because it's government taxpayers funding and it's available suitably de-identified. Oh, I think that's all very interesting. All right, I'll speed up. But so it potentially can be used by government and management to show each physician's performance and the the cost per care for each physician and the outcomes. It potentially could go down that direction. And that's one of the things that some doctors may be nervous about at the moment we have control, the more government puts money into developing this, the less certain we are is that it may come with strings and it may go public and for purposes outside of our control. Anyway, that's where we're at.
Thank you, John. We did have a question come through online, but I'm mindful of time, so we'll make the commitment to answer that question directly to the person who took the effort to send the question, so thank you and apologies. Can I just thank you, John, for a very...
Louise, I must ask, how many steps do you do a day? I'm curious.
Well, today's not a good day because I've been sat listening to you. But I've been averaging about 10,000 steps a day.
That's impressive. That is impressive.
I've been making concerted effort. John, can I say a big thank you for your time and a very thought-provoking session. And thank you for joining us. We will be sending around a survey to evaluate this afternoon's session, so please give us some feedback. Thank you to our guests online. I want to say a big thank you to my team for organising the day. You've done a tremendous effort. Big thank you to Helen in particular. A quick round of applause for Helen and the team. And thank you, John, as well. Round of applause for you as well. And safe journey back to Sweden when you eventually get back there.
Thank you, Louise.
And I encourage you to go back to your workplaces and start thinking about patient-centred care and using experience data and outcome measures. And we'd love to hear from you at Safer Care about what we can be doing to help you. So thank you and safe journey home.